Gautam, you could get the PowerPoint from Dr. Sonal?
Yes, ma'am. I have it, ma'am. I have it ready.
Okay. ఇప్పుడు మనము స్లైడ్ ఓపెన్ చేస్తే we know how many people are there waiting.
Yes, ma'am.
How do we know how many people are waiting, Amma?
Gautam?
We can see, ma'am, once we log in into the link, attendee link.
ఇప్పుడు మనము స్లైడ్ ఓపెన్ చేస్తే లాగిన్ అటెండీ లింక్ కాదమ్మా. వాట్ ఐమ్ ఆస్కింగ్ ఇస్ see people must have registered through Slido, no? The registration link for the quiz.
Yes, yes.
They will join through that only, no? They will not
Yes.
join through audience, right?
Yes, ma'am.
సో మనకి ఇప్పుడు ఎంతమంది వెయిటింగ్ లో ఉన్నారు ఎలా తెలుస్తుంది?
8 members ఉన్నారు, ma'am, currently.
8 are waiting on Slido, like PGs.
Yes, correct.
Okay, right.
15 people have joined, ma'am, till now.
Sunal, are we ready, Sunal? Or should we wait for another 5 minutes more?
Yes, I'm ready.
The team, I mean, all the rounds you will be telling or what?
Shiva, just I saw the message. They have not received link. I think he has sent now, so they should be joining in some time. Shabana is writing. Please send your email ID. Then I think Sham is sending them the link. They are trying to join, so let's wait for us. Shabana is joining.
Yeah. Yes, yes.
Shabana and Shiva Parvati. I'll call her.
मैडम शिवा पार्वती मैडम का भी ईमेल आईडी नहीं दिए थे.
श्याम एक पैनलिस्ट लिंक तो पोस्ट करो ना एक क्विज ग्रुप में, probably they can join.
No, ma'am, that can only be sent to that email
Mail,
ID. Yeah,
Okay,
I've sent.
Right.
Only सोनल मैम का था तो उनको भेज दिया.
ठीक है, okay, right.
क्विज का ग्रुप है ना, उसमें उसने रखा है, बट आई विल टॉक टू शिवा पार्वती.
I think Shabnam has joined Sonal. Shiv Parvati is left now.
हाँ.
Yes.
Good evening, ma'am.
Just I
Good
need
evening, Shabnam.
शिवा पार्वती मैडम.
Meanwhile, we can tell the attendees who are there in, I think, 10 numbers or something. If they are postgraduates, they can join on the quiz link rather than here. Or if they are just the audience, then it is fine.
She is not picking up the phone, Shiva Parvati.
आपके पास उनका राउंड है क्या कुछ सोनल?
हाँ, मैंने फोन लगा रही हूँ, लेकिन she is not picking up.
नहीं, आपके पास उनका राउंड है.
हाँ,
राउंड
है.
मतलब
हाँ,
क्वेश्चन से.
Yes.
ठीक. I mean, let us see. Probably if she joins, it's fine.
फर्स्ट तो शबाना का है, शबना उसके बाद उसका है, उसके बाद लास्ट मेरा है, तो बाय देन आई थिंक शी विल जॉइन इट.
She should be able to join. पर उनका मेल आईडी तो चाहिए. Either of you know her mail ID?
मेल आईडी तो है.
हाँ, मेल आईडी डाल दीजिए वो क्विज ग्रुप में. श्याम विल सेंड द मेल, मतलब वो लिंक उनका मेल में भेज देते. Then we can start off or something like that.
She has sent the presentation also on WhatsApp. From Urvashi Khan to host, not able to join the link. Yes, you are joining. Okay.
Shyam, Gautam or Shyam, can you explain to Dr. Urvashi Khan or somebody as to, you have
Yes.
posted the link, no? Just tell them
Yes.
from
Yes.
here, they'll be able to hear us.
Yes, ma'am. Dr.
Yeah.
Urvashi, if you have not registered earlier, right? Once you click on that link, there is a right side there's a button called click to register. You have to click on that, enter all the details, and then register yourself. Once you register, you have to use the same email ID to get into the login. That's how you will be able to get into the quiz. Thank you.
अभी कितने लोग ज्वाइन किए श्याम वो स्लाइडों में?
एक मिनट में बता रहा हूँ.
Sonal
25
Shivaparati
people
is
are
joining.
25.
Yes, she is joining in 5 minutes. She's on the way. She will take 5 to.
Gautam, how many people have joined?
25 people.
25 people have joined.
25. Okay. Who is Dr. Anuradha?
Good evening, ma'am. I'm
Madam,
Dr. Anuradha.
Madam, sorry. Madam, good evening, madam. Good evening.
Good evening. నువ్వు అడిగింది అది
మేడం నేను ఎవరు అనుకున్నాను మేడం క్విజ్ జాయిన్ అయ్యారనేసి. ఓకే మేడం, విల్ స్టార్ట్ మేడం. అనదర్ 5 minutes విల్ స్టార్ట్ మేడం.
Good evening, madam.
గుడ్ ఈవినింగ్ డాక్టర్ సోనల్.
Good evening, madam.
గుడ్ ఈవినింగ్.
Very glad you can join.
Yeah, I didn't expect madam to be here, so I was wondering who is she. Is PG है तो वो link में join करने के लिए I was just thinking. Sorry madam, apologies. I was not in that tune that way. I think again, Shyam, please tell whoever is there in audience to join for the quiz link now, because I think 19 minus 5, 14 people are there in the audience, 13 people.
Yes, ma'am. I'm putting up a message again.
Message again and tell them that this is a registration link to the quiz and all this.
Yes,
So
ma'am.
another 7:10, Sonal, we should start, no, Sonal?
Yes, yes.
Yeah.
So Shabana, the plan is like Manjusha मैन आप पहले तो start करें. Once you start the ball rolling, then we will give the quiz, whatever the rules of the quiz, followed by Shabana will present the glomerular diseases. And after every 30 seconds, the slide will automatically go to the answer. So once the answer slide is displayed, that means it is 30 seconds are over.
So ये सब तो quiz का instruction है ना, तो we can explain once we are on. I think probably once I introduce and then tell you to speak, probably you can give the instructions. I hope you have the PPT or one slide of the instruction जो आपने भेजा है मेरे को.
Yes, yes, yes. That is there in the presentation.
ठीक है, अच्छी बात.
And I've given all the slides to the tech team, so they will only be doing it. We will just read it out.
हाँ, ठीक है, ठीक है, ठीक.
I will run
Madam,
the
Anuradha madam, you want to say a few words or something, madam? I'll invite you also to speak.
No. What will I say, Manju?
Okay, madam. A few words to the PG is fine, madam. Otherwise, it's okay, madam. No,
Okay, no problem. I can.
Okay, madam. I'll invite you. I think 7:10. You give the countdown, no, Sham?
Oh.
Yes, ma'am.
Hmm?
Yes, ma'am.
Hello.
Madam, inka start kaలేదు, madam. I'll call you, madam.
Okay.
We request all the attendees who have joined, Praveen, Kim, Mohammed, Palak, Praveen, Preeti, Sanket, Shreyas, Urvashi Khan to join on the link. Please check the chat. There's a link that is posted. If you want to join the quiz, you can click on that link and register yourself and join for the quiz. We'll be starting in another minute.
Hello. Kannamma, எப்படி இருக்கேம்மா?
Can we start the countdown, Sham?
Yes, ma'am. 5, 4, 3, 2, 1.
Yeah.
We are live.
Yes. Good evening, everyone. Welcome you all for this third day of Penta Day activity of Women in Nephrology India on the occasion of the World Kidney Day 2024. So we have been conducting and organizing various events with the inclusion of the stakeholders who are involved in the kidney care services. As you all know, we had done on day one with the patient advocacy, and yesterday was on the International Global Leaders platform. And today we are here with you to include the postgraduates and trainees across the country in this regular platform that is a quiz, which will be interactive session with all of you. I know quiz is indeed a very excellent platform to learn quite a good number of points. So to conduct the quiz, we have with us the quiz master of the show, Dr. Sonal Dalal, who is a senior consultant nephrologist from Gujarat. She's also executive member of Women in Nephrology India. Joining her team, Dr. Shabana Nazneen, who is associate professor, Department of Nephrology, Osmania Medical College, Hyderabad. Joining them is Dr. Shiv Parvati, who is consultant nephrologist from Tirupati, Andhra Pradesh. So this is a team who is going to conduct the quiz for the next hour plus or something like that. But before I hand over the mic to Dr. Sonal, I request our patron of Women in Nephrology India, who has joined us, Dr. Anuradha Raman, who is senior consultant nephrologist, Sunshine Kim's Hospitals from Hyderabad, to say a few words and wish best of luck to all the postgraduates who have joined. Over to you, madam. Dr. Anuradha, madam.
Thank you, Manju. Good evening to everyone. I always find these quiz sessions very, very interesting. it's not just interesting to see the participants, but it's also a lot of learning for me also, because there are so many things I learn whenever I attend a quiz program. So, and especially quiz being conducted by Dr. Sonal, and I mean, I've been hearing this for past, ever since we started online quiz programs. I'm sure it's going to be an extremely interesting session. And of course, we also know Dr. Shabana and Dr. Shiva Parvati also have been active in conducting quiz. So I hope all the participants are ready to take on the masters, and I'm sure we are going to have a very exciting session. With that, I wish all of you best of luck, and may the best team win. Over to the organizers. Over to Manju.
Thank you, madam. Thank you so much. Thank you for the kind words, madam. Completely agree with you. Dr. Sonal is seasoned. She's like a queen of the quiz. So she conducts very excellent quiz sessions. So without much ado, I just repeat the same thing what the tech team has been telling. We see good number of people who has joined as audience. Among the audience, if any of you would like to participate in the quiz, there is a quiz link that has been posted, virtual.cme.quiz or something. Please register and join immediately. By the time you join, Dr. Sonal will be giving the instructions. So audience is, you will not be able to participate in the quiz. You will be just an audience for the quiz show. But in case you would like to take an active participation, please register and join immediately. Now over to Sonal for the instructions and for the further program. Over to you, Sonal.
Thank you, Dr. Manjusha and Anuradha ma'am, for the kind words. I'm sure all the participants are ready for the quiz, and I would like to give you some instructions before we start. Next slide. So the rules of the quiz are like, we will be having total 3 rounds today. Each round will have 15 questions. So total there will be 45 questions. The first round will be on the glomerular disease, which will be taken by Dr. Shabana. Then second round is on fluid and electrolytes and dialysis, which will be conducted by Dr. Shiva Parvati. And the third round is on transplantation, which I would take. The registered students are requested to log in with the credential which you have already registered with. Next slide. And the questions will be displayed in serial orders in an inset window, and the quiz master will explain the question. And after which the timer will be seen. Like when you are attending on the Slido, there will be a timer, a dotted line which will go, which ends at 30 seconds. So once the timer starts, the login area will display the question with the options, and the time allotted is 30 seconds per question. And you'll have to select a correct option, and then you have to click the submit button. Once you submit the answer, that is, once it is submitted, the message will come, thanks for submitting, which will appear briefly, and then further correction will not be possible. So when you click the button submit, you should be 100% sure that you are not going to be able to change it. So once you are sure about your answer, then only you submit it. The results will be displayed at the end of each session. So you will be able to track your status at each end of each round. And I'm sure you'll find this quiz very interactive and very informative also. I wish you all the best. And with this, we will start our first round, which is on the glomerular disease. Over to you, Dr. Shabana.
Thank you, Manjusha ma'am. Thank you, Anuradha ma'am. And thank you, Sonal ma'am. So first round, it's like about the glomerular diseases. All the best to all the participants. So first question is, all are true about the glomerular basement membrane, except it is made up of the collagen 4, laminin, nidogen, and proteoglycans. B is composed of 3 layers with the central dense layer, the two thin layers. Option C is thickness in males is 270 nanometers and females it is 326 nanometers. And option D is type 4 collagen of the glomerular basement membrane in humans has the alpha 1 to alpha 5 chains. Your time starts now. Time is up.
Time is up, ma'am.
Time is up. So answer is that is in the in males it is 373 nanometers and in females it is 326 nanometer. Next question. So match the following. One is HNE stain, silver methamine, pass, and the Mason trichome. A is mesangial matrix, thickening of the glomerular basement membrane. B is morphology of the interstitial and the tubular cells. C is the detailed study of the glomerular basement membrane. D is the mesangial matrix, basement membrane, and the immune complex deposits. So option A is 1C, 2B, 3D, 4A. Option B is 1B, 2A, 3D, 4C. Option C is 1B, 2C, 3A, 4D. Option D is 1B, 2A, 3C, 4D. Your time starts now. Time is up. Answer is C. That is the HNE stain will tell us about the morphology of the interstitial and the tubular cells, whereas the silver methamine will tell us about the detailed study of the glomerular basement membrane. Next question. Regarding slit diaphragm and the adapter associated genes are all except NPHS1, NPHS2. Option B is TRPC6. Option C is CD2AB. Option D is LMX1P. Your time starts now. Time is up. So answer is D, that is LMX1B. So to understand the podocytopathies, it is better to understand it's like the nuclear proteins and the genes, then the slit diaphragm associated genes, then coming to the mitochondrial genes, coding genes, then coming, it's like, suppose the SD associated genes and adapter genes are like a nephrosin, podosine, CD2AB. Whereas coming to the other nuclear proteins, it is like WT1 and the LMX1B. And inversing genes help us to understand these all help us to better understanding of the podocytopathies. Next question. Identify the famous personality. Frederick Akbar. B is the William Howship. C is the Richard Bright. D is the Jacob Chuck. Your time starts now. Time is up. So answer is C, that is he is an Richard Bright, who is a founder of the nephrology. And because of his, we started doing the urine for the proteins, and he has done great work, works like reports of the medical cases. Because of that, the nephrology has considered as a separate branch. Next question. All are included in the International IgA nephropathy prediction tool except option A, blood pressure, proteinuria at the biopsy time. Option B, EGFR and age at the time of the biopsy. Option C is the microscopic hematuria. Option D is the calculator can be used up to the 2 years. Your time starts now. Time is up. So answer is C, that is microscopic hematuria. We know that the IgA prediction, international IgA prediction score has about the, at the time of the biopsy, we should see the systolic blood pressure, diastolic blood pressure, then age, raise, then the MEST score, then coming to the, then the other thing is whether it is applicable. Earlier it was said that it is applicable up to 6 months of the post biopsy, but now the new workup post hoc analysis has said that it can be used up to 1 to 2 years of the post biopsy. Next question. Question 6, that is a 44-year-old lady, non-diabetic, came with the history of the pedal edema, no hematuria, and the CUV was showing the albumin 4+ and the no active sediments, and the 24 hours urine protein was 6 grams. She underwent the renal biopsy and it was suggestive of the membranous nephropathy, and serum PLA2R was negative. On probing the history, and she was giving us history of using the fairness cream. So all are true except in this scenario. Option A is like serum and the urine mercury levels. Option B is NEL1 positive. Option C is rituximab. Option D is all of the above. So time starts now. Time is up. So answer is C, that is the rituximab. Usually it is a drug-induced membranous nephropathy where because of the history that it contains of the high levels of the mercury. So skin whitening creams like still these are available on the Amazon and other Flipkarts. So all these creams have the high levels of the mercury which are causing the glomerular diseases. Not even the skin whitening creams, other causes which are causing the chronic mercury poisoning is like the traditional medications. The cough syrups and other medications which are Unani and herbal medicines which have the high levels of the mercury. So this mercury, it causes the glomerular damage and it causes the membranous nephropathy, and even some cases we can see the MCDs. And thanks to the newer antigens found in the membranous nephropathy like the NEL1, which is positive in every cases. It's like in positive in the primary cases, in also secondary cases, and also in the malignancy. Next question. Prophylactic anticoagulation in the glomerular nephritis is considered in all except option A, serum albumin is less than 20 to 25 grams per liter. Option B, frailty. Then option C, BMI is more than 35 kg per meter square. Option D, proteinuria more than 10 grams per day. Time starts now. Time is up. So answer is B. That is, we have to give the prophylactically full dose of the anticoagulants according to the KDIGO guidelines. That is the serum albumin 20 to 25. Again, it depends upon the type of the reagent we are using to assess the serum albumin, whether it is grisol green or purple. Then again, it's an indication like proteinuria more than 10 grams. Then BMI should be more than 35, and the genetic predisposition to the thromboembolism or any cases of the heart failure. And but we should not give where we are suspecting the falls and history of falls and the frailty. Next question. State the true or the false. Live vaccination can be given to the nephrotic syndrome patients if they are on less than 20 milligrams per day steroids and or on the immunosuppressive agent stopped for the 1 to 3 months. A is true, B is false. Your time starts now. Time is up. So answer is true. That is, vaccination is very important part of the when we are managing the nephrotic syndrome because patients are immunocompromised and we are giving the immunosuppression. So if the patient is on less than 20 milligrams, and if suppose a child who has not received the MMR, if child is receiving less than 20 mg, or if you have stopped more than one month, then we can plan for the live vaccinations. Next question. A 23-year-old girl, case of the biopsy-proven lupus nephritis on the maintenance with the MMF and the steroid, and she is in remission since 1 month, and she got recently married. So what advice you give her except Option A is like choice of contraceptive if she is preferring oral, the progesterone only pills in alpha positive and the APLA positive and the moderate to severe disease activity. Option B is avoid pregnancy more than 6 months of the inactive lupus nephritis. Option C is you want to continue the MMF during pregnancy. Option D is hydroxychloroquine can be continued in the pregnancy. Your time starts now. Time is up. So answer is C. That is, we avoid the MMF. In pregnancy, we have to modify the certain drugs. If she is planning for the pregnancy, we can advise her to go if oral choice of contraceptives is like the POP, progesterone only pills, because if it is APLA positive, it's better to avoid the estrogen containing pills. And if it's and should be like the patient should be remission for more than 6 months. And to reduce the risk of the pregnancy, we can continue the hydroxychloroquine and we can start the low dose of the aspirin before the 16 weeks of the gestation, and we can continue the glucocorticoids, SCQs, azathioprine, and tacrolimus and cyclosporine, depending upon the stage and the condition of the patient. Next question. Match the following: Zucker rat, BLB by C rat, human nephritis, and the New Zealand W by F1 rat, that is lupus, membranous nephropathy, diabetes, and the FSGS. Your time starts now.
Time is up, ma'am.
Time is up. Answer is D, that is 1C, 2D. Like this is a Zucker rat, which is a fatty rat where the obesity has been introduced into this rat. This is a diabetic model. And whereas the BLP and C mouse, they have the long ears, and this is like example for the FSGS, whereas the New Zealand is famous for the lupus. These are our animal friends which are helpful for our studies. Next question. All are below factors increase the relapse of the ANCA-associated vasculitis except option A is PR3 ANCA subgroup, B is baseline high serum creatinine, option C is receiving the low dose of the cyclophosphamide, and option D is ANCA positive at the end of the induction. Your time starts now. Time is up. So answer is B. That is, we have certain baseline factors and the factors after diagnosis and the treatment factors to say about the increased relapse for the risk for the ANCA-associated vasculitis. Like baseline factors, suppose if the patient at the time of the presentation is low serum creatinine, or if presenting with the extrarenal manifestations, involvement of the ear, nose, throat diseases, or the more extensive disease, or with the diagnosis of the GPA, or PR3 ANCA, they are more risk for the relapse. And factors after diagnosis is like history of relapse. If they have the more history of frequent relapses, and ANCA positive at the end of the induction, and rise in the ANCA titers. And treatment factors is like if you are giving the low doses of the cyclophosphamide, or and then immunosuppressive, sudden withdrawal of the immunosuppressive, and the glucocorticoid withdrawal. Next question. All are true about the rituximab secondary resistance except option A is down regulation of the CD20, B is resistance to the antibody ADCC, then urinary drug loss in the heavy proteinuria, and D is the emergence of the HACA. Your time starts now. Time is up. So answer is C, that is the urinary loss of the drug because of the more proteinuria. So if it is primary or secondary, if a secondary resistance means patient is receiving the treatment, but again with second dose or third dose, if we have the low response for the remission compared to the first dose after the first dose, it may be because of the various factors like the down regulation of the CD20, or it because of the ADCC, or it's like because of the emergence of the HACA. And so that may be the reason for the decreased response after the rituximab. Next question. A 47-year-old man, non-diabetic, known hypertension, but HbS-Ag positive, presents with the history of anasarca, and 24 hours urine protein is 8.5 grams per day, and he also has the left lower limb DVT, and biopsy was suggestive of the membranous nephropathy, and HBV DNA levels were like 15,000 international units per ml, and Plat2R is positive. You start all except. Option E is steroids and cyclophosphamide. Option B is start antivirals nucleotide analogs like entecavir, and option C is anticoagulants, and option D is AC inhibitors or ARBs. You want to give all except. Your time starts now. Time is up. So answer is A, that is we have to wait for the steroids and the cyclophosphamide, because according to the KDIGO guidelines, if HbS-Ag positive, and but here the case Plat2R are also positive. So in special situations, first we have to treat the infection, then we can plan for the other immunosuppressions like the CNIs. But after controlling the infection levels, if infection viral load is more than 2000, then at time we should have to start for the nucleotide anticoagulant analogs. The next question, match the following. First is protect, EPP-IK-EPIC, SPAR-VASAR, then duplex. A is FSGS, IgA nephropathy, pediatric proteinuria glomerular disease. D is ANCA. So option A is 1D, 2C, 3A, 4B. B is like 1B, 2C, 3D, 4A. C is 1B, 2A, 3C, 4D. And D is 1A, 2C, 3B, 4D. Your time starts now. Time is up. So answer is B. That is, this is all the trials which included the sparsentan. So the trials with sparsentan is like in FSGS it is duplex trial, in IgA nephropathy it is protect trial, and this is in pediatric patients with the proteinuria glomerular diseases. And the SPAR-VASAC is ANCA-vasculitis. So the sparsentan is available in the form of the 200 and the 400 mg tablet form, which is like a brand name like Filspari. Next question. Identify the famous personality. Option A, George Oliver. Option B is Frederick Monk. Option C is Paul Kemmelstil. Option D is Robert Koch. Your time starts now. Time is up. So answer is he's in Dr. Kemmelstil. He's a German pathologist. We should not forget him because of him this KW lesion's name was given, and he has worked with a physician like Dr. Wilson, and this KW lesions name was given on behalf of his work. Thank you.
We have finished the first round, ma'am. We will show the leaderboard in some time. Yes.
I hope everyone enjoyed the quiz, and let's let the best candidate win. So can we have the results?
2 more minutes, ma'am. We'll show. The final question is happening there.
बोलो।
These are the leaderboard, ma'am. It is shown on the screen share as of now.
So it is as per the like number of points they have received.
Yes, ma'am. If you see Shreyas, out of 15 points, she has scored 13. Fahad 13. And
So
Govind.
Shreyas and Fahad are tied for the first place.
Yes.
Following which Dr. Govind Jaiprakash, he's on 12 points. That is on second number, and third position we have three candidates who are tying.
We have to
So,
see the time also, madam. उसके बाद जो time है, कितना time में वो answer किया is also.
so yes, when there is a tie, we will see who has solved the question in minimum time. So this is also very important point you should realize.
Yes.
That if you know the answer, don't wait for 30 seconds to get over. Immediately you give your answer, because when there is a tie, we will give a winner as per the person who has solved the in minimum time. So as per this, the Govind is at third position. Congratulations to all three winners, and wish you all the best to the rest of all the candidates. And with this, we will go to our second round, which will be done by Dr. Shiva Parvati. Over to you, Dr. Shiva Parvati.
Yes, ma'am. Good evening, Dr. Anuradha ma'am, Manjusha ma'am, and Sonal ma'am. And I wish you all the best for all the postgraduates. Now I am going to conduct the quiz on dialysis and fluid and electrolyte management. First question, please. So this is the first question. All the following is true regarding the fluid management in acute pancreatitis, except option A is IV ringer lactate is the preferred fluid in early 24 hours. Option B is acute kidney injury and mortality is more common in patients who received aggressive fluid resuscitation beyond 24 hours. Chloride-rich solutions are associated with increased incidence of acute kidney injury. And option D is abdominal compartment syndrome is diagnosed if intra-abdominal pressure is greater than 12 millimeters of mercury in acute pancreatitis. Your time starts now. I hope the tech team is following the time. They would inform
Yes,
me if it
ma'am.
is. Yeah.
Yes, yes, ma'am.
So time up.
Yes, ma'am.
So the answer is option D. Abdominal compartment syndrome is diagnosed if the intra-abdominal pressure is more than 20 millimeters of mercury. It is very important because it is one of the modifiable cause of AK in patients of acute pancreatitis. So you should monitor intra-abdominal compartment pressure if the patient is not recovering from the acute kidney injury in acute pancreatitis. Next question. Heracles trial is about. Option A is hypertonic saline did not reduce the total fluid volume administered in the ICU in critically ill cardiac surgery patients. Option B is hypertonic saline did not reduce the total fluid volume administered in critically ill neurosurgery patients. Option C is hypertonic saline did not reduce the total fluid volume administered in oncosurgery patients. And option D is hypertonic saline did not reduce the total fluid volume administered in critical ill sepsis patients. Your time starts now.
Time is up, ma'am.
Yeah, option. Time up. Answer, please. So the answer is option A. In this particular trial, they have seen that if we use hypertonic saline in post-cardiac surgery patients, can we reduce the total amount of fluid administered? Because in most of the post-operative patients, fluid overload is one of the common indications for initiation of RRT. However, not shown any advantage with the use of hypertonic saline. Next question, please. Question number 3. Which of the following fluid or electrolyte abnormality is seen in some patients after the relief of bilateral renal obstruction? Option A is hyperkalemia. Option B is hypermagnesemia. Option C is hypernatremia. Option D is hypovolemia. And option E is both C and D. Your time starts now.
Time is up.
Yeah, the answer is option E. That is, whenever most of the times you will get call from your urology fellows after placing some digest and the patient behaves irrelevantly with altered behavior. So most of the times, because of the massive diuresis, they will undergo hypotension and hypernatremia, and patient will be in altered behavior because of hypernatremia. So you should be ready to treat them. Next question, please. All of the following drugs are associated with SIADH except option A is carbamazepine, option B is vincristine, option C is cyclophosphamide, and option D is lithium. Your time starts now.
Time is up. Ma'am, time is up, ma'am.
So time. The answer is option D. Lithium is used in the treatment of SIADH and it is not responsible for SIADH. Next slide, please. PLUS trial is about. Option A is there is no mortality benefit with balanced multi-electrolyte solutions compared to saline in critically ill adult patients. Benefit of bicarbonate. Option B is benefit of bicarbonate solutions to prevent contrast-induced AKI. And option C is vitamin B complex infusion to prevent the incidence of AKI in critically ill patients. And option D is role of furosemide stress test in AKI management. Your time starts now.
Time is up, ma'am.
Time up. The answer is option A. That is, this trial has been done to prove that most of the anesthesiologists or the critical care specialists, they tend to convince the nephrologist telling that the balanced and multi-electrolyte solutions are better than normal saline. But they have not. This study has particularly established that they are not of much use in critically ill patients to prevent either AKI or the mortality. Next slide, please. Question number 6, that is 58-year-old male who is a diabetic and stage renal disease on maintenance dialysis. He was regular to dialysis since 3 years with left BC AV fistula. But of late he complains of breathlessness and he got admitted for recent episodes of acute pulmonary edema twice in the last 1 month, despite minimal interdialytic weight gain. So his patient is regularly undergoing dialysis, but still he is getting admitted for acute pulmonary edema. An AV fistula Doppler was ordered by the nephrologist. Which parameter is the most important in diagnosing the present condition of the patient? Option A is axis blood flow. Option B is axis inflow caliber. Option C is collaterals of the axis. And option D is axis outflow caliber. Your time starts now.
Time is up, ma'am. Dr. Snehal? Ma'am, can you take over? I think Dr. Yes. इसका आंसर ये है मैम.
Next, the correct
Answer
answer is answer A. The excess blood flow because the patient has features of high output cardiac failure and can be diagnosed when the excess blood flow is greater than 2000 ml per minute.
Hello? Yeah,
yeah.
ma'am. I just back, ma'am. Yeah.
Yes, ma'am. We can continue. Next question.
Next question. Here is a 25-year-old male patient who is again end-stage renal disease on maintenance dialysis for 3 times in a week with right IJV access for the last 3 weeks. He had fever with chills for the last 2 days. So we have suspected a catheter-related bloodstream infection and he was started on IV antibiotics, vancomycin. But the culture grew Staph aureus. Which of the following is true regarding the patient except the antibiotic should be continued for 2 weeks. 2D echo should be done if the patient has persistent fevers. And the antibiotic should be continued for 4 to 6 weeks if the patient has associated osteomyelitis. And he needs CBC removal if the patient has persistent bacteremia. Your time starts now.
Ma'am, time is up, ma'am.
Time up. So the answer is option A. Because if the culture grows Staph aureus, the minimum duration of treatment of antibiotics is 3 weeks, which should be emphasized. Otherwise, the patient would land up in complications like septic emboli, endocarditis, and osteomyelitis. Next slide, please. So question 8, which of the following clinical test is used to diagnose high output cardiac failure secondary to AV access? Option A is augmentation test. Option B is Allen test. Option C is Nicolanti-Branham sign. And option D is 1 minute check test. Your time starts now.
Ma'am, time is up, ma'am.
Time up. The answer is option C, Nicolanti-Branham sign. It involves the manual compression of AV axis for 30 to 60 seconds, which leads to decrease in heart rate and increase in systolic blood pressure and decrease in cardiac output. This is very, very important because unless you suspect and treat high output cardiac failure in a chronic dialysis patient, it's difficult to diagnose and treat. Next slide, please. The cohort of patients undergoing hemodialysis at a particular center has complaints of dizziness and weakness compared to the last month. So hence they have ordered CBC for all the patients, which showed anemia in almost all the patients despite adequate EPO dosage and regular HD and adequate KTO over week. So the unit decided to check the technical aspects of the HD unit and water quality. Which of the following disinfectant used in the unit could be responsible for this situation? Option A is pyristic acid. Option B is sodium hypochlorite. Option C is formaldehyde and option D is hydrogen peroxide. Your time starts now.
Time
is up. The correct answer is option B. This is very important because if you are doing disinfection with sodium hypochlorite and you do not check the residual chlorine level with the reagents, the chlorine is responsible for producing hemolysis, which can be either acute or undetected chronic hemolysis, usually results in anemia. Usually, you should suspect if all of your patients are not achieving adequate hemoglobin levels despite adequate dialysis and hemoglobin EPO doses. Next slide, please. Question number 10. Which is true regarding heparin-free dialysis? Extracorporeal blood flows are typically maintained between 120 to 300 ml per minute. And 25 to 30 ml saline flushes are administered every 15 to 30 minutes into venous limb of the dialyzer. Option C is 25 to 30 ml of saline flushes are administered every 15 to 30 minutes into arterial lane of the dialyzer. Option D is extracorporeal blood flows are kept at 250 to 500 ml per minute. And option 1 is both C and D. Option 2 is both A and B. Option 3 is both C and A. And option 4 is none of the above. Your time starts now.
Time is up, ma'am.
So the correct, next slide, please. So the correct answer is option 1. This question I particularly kept it because as long as we are in medical colleges and institutes, all the dialysis technicians are also covered by senior technicians. So we need not to tell. If you do heparin free, they will do. But once you come out, you have to tell the instructions also. So heparin free dialysis, the flow should be maintained little bit higher in order to prevent clotting. And also the flushes should be given every 15 to 30 minutes into the arterial line of the dialyzer. The volume is also important, 25 to 30 ml. And you should make sure that whatever fluid you give, that should be taken by the ultrafiltration. Next slide. Question number 11. The following is true regarding HIDE, that is hemodialysis access-induced distal ischemia management, except the goal is to reduce the access blood flow below 1200 mils per minute. Mild cases can be treated conservatively with reducing the speed of the blood pump and using warm gloves. The time of onset is usually after chronic usage of the access beyond 3 to 6 months. And RUDI, that is revision using distal inflow, is one of the definitive surgical procedures used for HIDE. Your time starts now. I think the time is up. So the correct answer is the option C, that is whenever the ischemia need not be happening in a long-term dialysis patient. It can occur immediately after the creation of the access also. Recently, I've seen a patient who developed wrist drop immediately after creating an AV fistula. Similarly, they develop paresthesia. So it is very important to identify this because of late we have more definitive surgical procedures to deal with these things. Next slide. Which is false regarding the biochemical markers of volume overload in dialysis patients. Option A, both BNP and NT-proBNP are cleared by hemodialysis and peritoneal dialysis. Option B is BNP and NT-proBNP are elevated in dialysis patients due to decreased clearance by reduced kidney function. Option C is NT-proBNP has longer half-life compared to BNP. And these markers are, option D is these markers are elevated in dialysis patients due to the increased frequency of LVH and ventricular dysfunction in dialysis patients. Your time starts now.
Time is up.
The correct answer is option A, that is NT-proBNP or proBNP are cleared by hemodialysis, but their clearance in peritoneal dialysis is not well established and it is very less. Next slide, please. Which of the following is true regarding ultrafiltration in peritoneal dialysis? It is defined as a failure to remove more than 200 ml on a 4.25% PET, or it is defined, option B is failure to remove more than 400 ml on 2.5% PET. Persistent and excessive fluid overload despite an icodextrin exchange is a clinical clue to excessive peritoneal lymphatic reabsorption. Sodium removal on APD is more than CAPD due to CV. Your time starts now. Time up. So the correct answer is option C. That is whenever if you are not ultrafiltration failure in PD patients is very difficult to manage, and excess peritoneal lymphatic absorption is a very difficult thing to diagnose. So once you put the patient on icodextrin, still the patient is not responding, then you have to think of excess peritoneal lymphatic reabsorption. Next slide, please. All are true of peritoneal eosinophilia except infectious peritonitis is more common when eosinophil count is more than 30% of WBC count. It can occur in encapsulating peritoneal sclerosis. Option C is hypersensitivity to PD catheter plastocysts or sterlins can cause it. And option D is usually occurs in the first 3 months after initiating PD. Your time starts now. Time?
Yes, ma'am.
Time is up. So the correct answer is whenever you see peritoneal eosinophilia, in order to distinguish between infectious and non-infectious etiology, you should compare it with the total WBC count. If the eosinophilia is more than 30% of the WBC count, most likely it is because of a non-infectious etiology, and waitful watching will help in the clearance of the eosinophilia rather than subjecting him to long-term antibiotic courses. Next slide, please. Which segment of the kidney reabsorbs highest percent of the filtered sodium? Option A is collecting duct. Option B is distal convoluted tubule. Option C is loop of Henle, and option D is proximal convoluted tubule. Your time starts now. Time is up, I suppose. Hello? Yeah, the correct answer is option D, that is proximal convoluted tubule. With this, we end the round on fluid electrolytes and dialysis. I hope I tried to put the questions close to practical issues so that it will be helpful for your future practice. Thank you, Sonal ma'am and Anjusha ma'am, for giving me the opportunity.
And the questions were very good, very practical, and I am sure all the students must have learned a lot. And I think the tech team now would be able to give us the update on the results.
Leaderboard. Yes, ma'am. 1 minute, ma'am. The last question is running.
Okay, so yeah, there will be some gap in the.
Ma'am, Sonal ma'am, with your permission, I would like to leave, ma'am. I had some other appointment. Can I leave, ma'am?
Sure, sure.
Thank you. Thank you, ma'am.
So Fahad,
here is the leaderboard, ma'am. Yeah.
Fahad again is at the first step. He's on. He has got 25 marks. Close to him is Navneet. He is on 23 points, and Govind is still at the same position at position 3. Dr. Govind having a score of 21. So congratulations, all three of you. And as I can see, most of you are very close to each other, and so there is a very good and tough fight. So wish you all the best for the final round, which we will start. This round is on transplantation, which I think all the nephrology students are very close to their heart, and we all have a lot of newer knowledge and newer things which are coming up in transplant. So it is difficult round also. So let's hope that you do it well. Wish you all the best. And with this, we start our first question in the transplantation round. The question number 1. Which biomarker significantly predicts the delayed graft function and reduced graft function in long term after transplant? Option A, urinary NGAL. Option B, serum uromodulin. Option C, CXCL10. And option D, donor-derived cell-free DNA. Which biomarker significantly predicts DGF? Your time starts now.
Ma'am, time is up.
Time up. And the correct answer is urinary NGAL. Urinary NGAL. Next slide. So it is a predictive value of donor urinary NGAL, and it is a marker of injury. Urinary kidney injury molecule 1 and urinary fatty acid protein binding protein for DGF was recently documented by study by Ku et al. But finally, in recent review, high urinary or serum NGAL levels were found to be have to serve as a predictor of DGF and were associated with reduced graft function at 1 year. So this is the important molecule, urinary NGAL, to predict the DGF. Next slide. Question number 2. As per the CTOT4 study, urinary mRNA level appears to be diagnostic and prognostic of acute cellular rejection in kidney allograft, all except option A, CD3E mRNA, option B, IP10 mRNA, option C, 18S RNA, and option D, MIR182S5P. Your time starts now. So these are very difficult molecules to make by heart, but once we start commonly using them, when it will be practically available, we should know what is indicator of which particular injury.
Ma'am, time is up.
Time up. The correct answer is MIR182-5P. So next slide. This is associated with delayed graft function and was not a part of CTOT4 study. So that's why this is the correct answer. It is not a part of this study. Next question. Question number 3. In atypical HUS caused by mutation in which of the following is least likely to recur post-transplant? That is not likely to or least likely to recur post-transplant. Option A, factor I. Option B, MCP. Option C, C3, and option D, factor H. Your time starts now.
Ma'am, time up, ma'am.
Time up. The correct answer is MCP. Next slide. MCP is a membrane-bound protein and the allograft expresses normal membrane-bound. So it is least likely to cause recurrence of HUS among the listed other proteins. The other listed proteins are circulating factors and they are more likely to be associated with recurrence of HUS in transplant, except MCP. Next question. Question number 4. Which of the following genomic tests will be used to stratify kidney transplant recipients into high versus low responders in BioDream study? Option E, in IFN Infi Lambda ELISpot. Option B, Kappa Spot. Option C, Kappa Spot. And option D, all of the above. Your time starts now.
Ma'am, time is up, ma'am.
Time up. The correct answer is option A. It is interferon gamma ELISpot. Next slide. In the kidney transplant trial design of BioDream Celamin is a prospective multicenter randomized trial utilizing interferon gamma ELISpot to stratify kidney transplant recipient into high versus low responders. Only low responder patients will be randomized to receive either standard immunosuppression or low dose immunosuppression. And so the trial will evaluate the donor specific cellular allo response for immunosuppression minimization. So this is a very good trial which would help us in deciding whom we can minimize the immunosuppression. Next question. Question number 5. Increased level of which of the following HLA is associated with lower risk of graft rejection in transplant recipient? Option A, HLA-C, option B, MIC-B, option C, MIC-A, and option D, HLA-G.
Ma'am, time is up, ma'am.
The option is, the correct answer is HLA-G. Next slide. So in non-classical HLA molecules are HLA class 1, like proteins that have limited polymorphism. They have associated, they have aroused interesting among kidney transplant specialists because they modulate the natural killer cell function. And in addition are targets of alloantibodies. One prominent example is HLA-G. It is highly expressed in the placenta where it contributes to the fetal tolerance by inhibiting the natural killer cells. So this HLA-G in kidney transplant recipients are associated with low risk of graft rejection, and as compared to the other molecules like mica, and they have a higher risk. So HLA-G is important for it has a better for graft rejection is prevented. Next slide. Question 6. Which of the following drug is not a moderate inducer of CYP3A? Option A, modafinil. Option B, armodafinil. Option C, bosentan. And option D, efavirenz. Your time starts now. It is not a moderate inducer. It is it is a
Ma'am, time is up, ma'am.
time up. The correct answer is option B. Next slide. So as you can see here, the strong inducers are carbamazepine, phenytoin, rifampicin, and St. John's wort, whereas moderate inducers are bosentan, efavirenz, and etranacogene, modafinil, and not the one which we said, that is armodafinil. Next question. Question number 7. All of the following are true about applets except option A. Applets are clusters of polymorphic amino acids, discontinuous or linear, that are located on the surface of HLA molecule. Option B is applets have been called functional epitopes. Option C, they recognized by anti-HLA antibodies within the larger 15 to 22 amino acids of an HLA epitope. Option D, the number of donor-recipient applet mismatch can be determined using a computer algorithm called HLA matchmaker. And option E, applet mismatch in HLA-DQ does not confer a significant risk for de novo DSA formation, rejection, and graft failure after kidney transplantation.
Ma'am, time is up, ma'am.
Time up. The correct answer is option E. Applet mismatch in HLA-DQ does not confer a significant risk for de novo DSA. So this is a wrong. Actually, applet mismatch in DQ also appears to confer significant risk of de novo DSA sensitization. And so that is the correct answer. Next question. Question number 8. All of the following scenarios may lead to unfavorable cross-match result in the setting of negative virtual cross-match, except option A, presence of non-HLA antibodies. Option B, presence of IgM antibodies in recipient having an autoimmune disorder. Option C, presence of historical DSA. And option D, recent treatment with basiliximab. Your time starts now.
Time is up, ma'am.
Time up. The correct answer is option D, recent treatment with basiliximab. Next slide. So as an increase in number of patients awaiting transplants are being treated with monoclonal antibodies that can interfere with cross-match testing, such as rituximab or altuzumab or ATG. So these can interfere with your cross-match techniques, but basiliximab is not interfering with the technique. So the correct answer was option D. Next question. Here is an image question. What is the histological diagnosis of allograft kidney biopsy, which is given here? Option A, tubulitis. Option B, glomerulitis. Option C, interstitial fibrosis. And option D, arterial hyalinosis.
Time is up.
Yes. The correct answer is option D, arteriolar hyalinosis. Next question is question number 10. Which of the following statements about historical DSA is false? Option A, absence of pre-transplant DSA does not imply lack of pre-transplant sensitization. Option B, longitudinal examination of single antigen bead assay screening may reveal historical DSA and indicate immunological memory. Option C, there are now clinically validated assays available to challenge latent memory and determine whether low titer DSA will increase post-transplant. And option D, historical DSA indicate immunological memory and this patient should be counseled about a higher risk of rejection and immunosuppression should be tailored keeping in mind the memory response. Your time starts now.
Time is up.
Time up. The correct answer is option C. There are now clinically validated assays available to challenge latent memory and determine whether low titer DSAs. The explanation for this is next slide. Although a longitudinal study of historical DSAs may provide a valuable insight into prior sensitization status, risk of rejection, and also may guide the tapering of immunosuppression post-transplant, and monitoring of historical DSA titer has not been validated clinically in the limited studies that have been published so far, and hence it is not recommended by any of the internationally accepted guidelines to monitor the historical DSAs. Next question. So the next question is question number 11. Which of the following scenario is considered in case of positive virtual cross match in negative flow cross match? Option A, autoantibodies. Option B, all allo antibodies towards denatured HLA. Option C, incomplete donor typing. And option D, non-HLA antibodies. So time starts now.
Time is up.
Time up. The correct answer is option B, allo antibodies towards denatured HLA. Next slide. As you can see in this presentation, the graphical presentation, next. If we have this positive virtual and negative flow, the possibility is because of the denatured DNAs. Next question. This is a question number 12, again, a image question. Post-renal transplant in 2016, patient is having raised creatinine and urine protein 2+, and biopsy is done. What is the diagnosis? Option A, acute cellular rejection. Option B, acute antibody-mediated rejection. Option C, chronic allograft nephropathy. And option D, BKV nephropathy.
Ma'am, time is up.
Time up. The correct answer is option C, that is chronic allograft nephropathy. Next slide. As you can see in this slide, it is showing severe chronic allograft nephropathy with features of CNI toxicity and acute tubular necrosis. There is marked hyalinosis and moderate fibrointimal thickening. Almost 60% of interstitium is showing fibrosis. There is no tubulitis or no viral inclusions in this, and there is no evidence of acute rejection in this. Next slide. We move on to number 13. In a 42 years male post-kidney transplant patient having HCV infection genotype 1, which of the following DA you should not be given? Option A, sofosbuvir, ledisavir. Option B, sofosbuvir, declatasavir. Option C, grazoparavir, alisbavir. And option D, glecapravir and pibranestavir.
Madam, time is up.
Time up. The correct answer is option C, grazoparavir and alisbavir. Next slide. As you can see, there is this very good algorithm which gives us a guideline in which genotype, which molecule which should be used. And so this is not to be used. Next slide. Question number 14. Elevated donor-derived cell-free DNA levels are seen in all of the following except option A, chronic allograft nephropathy. Option B, immediate post-transplant hours. Option C, acute pyelonephritis. And option D, acute tubular necrosis. Time up, I think.
Yes, ma'am, time up.
The correct answer is option A. It is chronic allograft nephropathy. Next slide. Next. Donor-derived cell-free DNA represents an average 0.3% of the total cell-free DNA in plasma of a stable kidney transplant recipient, and levels increase during acute rejection and to a lesser extent during acute pyelonephritis and ATN. A kinetic pilot study of donor-derived cell-free DNA after transplant show high median level in the immediate post-transplant hours around 20%, but which rapidly decreases to in first day to around 5% and then stabilizes to 1%. So not in chronic allograft nephropathy, it will not be seen raised. Next question. So we now move on to our last question. Question number 15. Which of the following immunosuppressive drugs does not produce osteopenia? Option A, corticosteroids. Option B, cyclosporin. Option C, tacrolimus. And option D, everolimus. Very easy question. I am sure everyone will be able to answer this question.
Ma'am, time is up.
Time up. And the correct answer is option D, everolimus. It will not have any side effects on the bone. There is no osteopenia in patients who are being given the everolimus. As you can see, osteopenia is seen with steroids and CNIs, but there is no osteopenia with mTOR or MMF or ESA. Next slide. So with this, we come to the end of our quiz. Thank you so much. I hope you all enjoyed it and you could solve it. And there must be some apprehension and excitement about the results. And let's hope we get the best results and a very tough and tight competition.
We will share the leaderboard in a minute, ma'am.
Manjusha ma'am.
Yeah, excellent quiz, Sonal. I think everybody has done an amazing job, Dr. Shabana and Dr. Shiva Parvati. Very thoughtful and thought-provoking questions indeed, like clinically applying questions, clinically applying scenarios, and of course the basic knowledge that we are ought to know, all these things. So it is a very inclusive quiz, but nevertheless, probably we can ask the trainees if they have certain inputs to be given to us. They can post their messages in the box so that we also understand, like in a futuristic sessions, how to take it forward. Sonal, would you like to announce the result? I mean, I think the
Leaderboard.
Yeah.
Fahad has consistently kept his position, so he's still at the number 1 position, and he has scored very good 35 points. So congratulations, Fahad. Number 2, Navneet was first. In first round, he was in a much higher position, but then in second round, he had lost. But again, he has regained back, and he has done very good in third round, and so he has secured the second position. Navneet is at second position, and we have a new face on number 3 position, that is Preeti Anand. Congratulations, Preeti Anand, for securing the third positions. So there is a significant tie, and as I can see, number 4 is also at the same position as Preeti, but with the time it is only 1 second difference, and that's why Preeti scores over Praveen Kumar, who's at number 4 position. Congratulations to one and all. You have all done very good, and I can see everyone has attempted a very good number of questions at good points. Congratulations, everyone.
Yeah, I mean, thanks, Sonal. I think, yeah, as you said, there's been a consistency, but I'm sure it was very useful to the participants, to the students. We look forward to many more such quiz sessions to be coming in the future. But anything that needs to be told to us as an input or probably as an feedback to us is almost always every time welcome, because we can also have certain constructive inputs from the trainees, and then we can take it forward. So congratulations to everyone who have, in fact, it is appreciable that good number of participation was there. But first 3 people are supposed to be the winners. Anyway, the first 3 people announced by Sonal. Congratulations to everyone. And thank you so much. We also appraise you that this is being done as a part of a Penta Day activity by the Women in Nephrology India. So today is the day 3 activity. We had 2 more days to go. This is tomorrow and day after. We request everybody to join for our activities in the audience link that is being shared with everyone on the social media as well as on the mail. So thank you. Thank you so much, Sonal, Shabana, and Shiva. Thank you.
Thank you.
Thank you. Thank you, Shyam and team.
Thank you, ma'am.
Yeah, thank you. Good night. Yeah.